Very good evening and a warm welcome to all the respected participants. My name is Kiran Kumar. I am representing GE Healthcare Cardiovascular Ultrasound segment. Today we are conducting an exclusive clinical lecture on LV systolic function. What should we report? Is EF alone sufficient? On our XP Connect webinar education series powered by Vivid Cardiovascular Ultrasound technology from GE Healthcare. As the world navigates through the extraordinary challenge presented by the COVID-19 pandemic, we are inspired to support healthcare providers around the world in addressing it. Heart disease is now a leading individual cause of disease burden in India, as we all work towards the same cause of healthier India. Early intervention is the key, which requires a shift from a traditional way and take a more comprehensive view of treating and handling of the patient. The most and quickest assessment made using echocardiography is ejection fraction. As there are new technology and features available in the world of echocardiography, is EF alone going to be sufficient? For the same today, we have with us one of the renowned names in the field of echocardiography, Professor Dr. K Chandrasekaran sir from Mayo Clinic and Apollo Hospital, Chennai. I welcome you, sir. Professor Dr. K Chandrasekaran sir is a well-known name in the cardiology community and has been contributing immeasurably, be it educationally, initiatives, books, training, relentlessly to name few areas. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If we experience temporary interruption in the transmission, kindly bear with us. We'll sort it out immediately and resume. I now welcome the respected faculty, Professor Dr. K Chandrasekaran sir, to address our viewers with his clinical talk on LV systolic function. What should we report? Is EF alone sufficient? Over to you, sir.
Thank you. Good evening. Are you all able to see it?
Yes, sir, we can.
All right, then. Okay, I'm sorry about it. But anyway, I think that one of the major aspects of the heart is basically to allow us to do our day-to-day activity without any symptoms, which means that it should be able to fill the low enough pressure and it should be able to pump the blood at the sufficient enough pressure so that the tissues can get perfused. And how does it do this? I think if you look at here, Sir Arthur Keith, the famous person Keith and who discovered the SA node, he stated about almost 100 years ago, more than 100 years ago, that ventricle contracts in a coordinated antagonism. What do you mean by that? So it has got a lot of muscle fibers, oblique fibers outside and vertical fibers inside. In between it has got circular fibers. And several people have been trying to say that there is a continuous muscle bundle, but it has been proven beyond doubt by Bob Anderson from London that there is no separation at all, but the fibers themselves have this arborization and connection. But nevertheless, the inner and outer oblique and vertical fibers, in between this is muscular fiber, both of them, all of them contract, and when contracts, oblique fibers contract, the base of the heart, which is mitral and tricuspid annulus, moves towards the apex, whereas when the circular fibers contracts, the heart squeezes along its long axis. So this is the reason both of them are contracting at the same time, but each one of them are exerting a different pressure. As a result, the blood is propelled into the aorta along the apex and aortic axis. So these are the fibers, basically. This is the apex and this aortic root. This is the long axis along which all these outer oblique, inner vertical and circular mid fibers contract, they propel the blood. They also have to have a two fulcrum. One is the fulcrum here at the aortic root, the other one is at the apex. Without this fulcrum, the heart contraction cannot be effectively managed. Now, where is the proof for these fibers? This is the work done by Dr. Sonnenblick in 1969 with Dr. John Ross. Look at the endocardial area. The fibers are vertical. Mid-myocardial area, they're circular, and epicardial area oblique. But there is no separate bundle as coming as a single fiber. So there is no such thing as a single fiber, but it's a single continuation arborization of the myocytes. But anyway, the major part of the heart function is you need to have the myocardium that should be able to function. Once it gets the impulse from the nerves, it should be able to contract, it should be able to send this, signals to the myocytes so that calcium can go in and contractions can occur. So second part is individual myocytes, they all start contracting. So effectively as an organ, it's able to start contracting. That results in the change in the shape of the ventricle. And once the contractility occurs, change in the shape propels the blood into the aorta. So these are the major factors. Now, traditionally, systolic function, we thought, when the echocardiogram came about in late 60s, late 50s and early 60s, we just had a blinded single mode probe. So we were able to see it and we were able to take whatever you can see and we were able to look at the cardiac function and we were able to see the chambers on an eye-stick view, and we were able to try to come up with the formulas to get some function like end-diastolic dimension, end-systolic dimension. From that, people have developed various formulas to develop the ejection fraction as well as fractional shortening as well as to get at the mass and EF. Now, we do know that M mode by itself, it provides contractility data along a single line, provided it is perpendicular to the heart, but it does not reflect any other dimension. The heart could have enlarged on the laterally, or heart could have had a damage in the apical area. We won't know it. So it is only valid also as long as the ventricle is symmetrical. So then the formula works. If there is anything that's going to disturb the normal geometry of the heart, any pathology, then all of them are off the bet. But here, look at here. This is a 2D echo of a person with 70-year-old male, and you see the LV is already angulated. LVH is there, aortic valve is sclerotic, and look at the angulated septum. Now, if you try to get an M out through the beam, it's going to go through in an oblique manner. Whereas now the echocardiogram in the recent days, in the last 10 years, anatomical M mode has come where you can measure, put it here. But on the other hand, before that itself, we used to use 2D guided measurements, DNA measurements to find out why were we doing all these things. Because all the data thus far, what we have had, is based on the M mode dimensions. Our decisions on sending the patient for surgery for valvular heart disease and assessing the patient for treatment whether the ventricle is smaller or not, everything is based on the linear dimensions that we got it. Even though over the last 10 years we've been using volume, and especially over the last 7 to 8 years, 3D has been there, till we use the data from the M mode. So that's the reason we do need to do it, but on the other hand, I'll show you what the other features are. So there are several formulas that have come about based upon all these formulas does work only when the ventricle is not changing its shape. When it conforms to the normal geometry, all these formulas do work. For example, area length, and here is the area length, the LV short axis, LV apical four-chamber view, and you can measure the area length, and based on the formula you can use. And this is a biplane image where Simpson's method, disk method, biplane area length disk method, you can use it, and this also gives you a measurement of LVEF. And one can get a nice assessment, combination of the both views. Apical four-chamber view is 62%, and apical two-chamber view you have about 52%, average is about 59%. So here the advantage is geometry is taken care. If there is abnormality in geometry, your area is, you are able to use it, you are able to overcome that. So this provides you a much more better EF. Even here, if there was a wall motion involving, so this is a method which has been completely supported by ASC and ESC. But the problem here is, in this case, you see the patient four-chamber view and two-chamber view, and see the wall motion and geometry change in the basal inferior area. This is fine. You can measure the EF from this, and you can also measure the chamber volume. But say if you had had it in the anteroseptal, your biplane should be guided to use that area. Otherwise, your EFs are going to be problematic. So this is one of the cautions one has to keep in mind. So here in this patient, the EF is about 55% using biplane method. Now, things have come along. This is one of the GEs. The matrix probe that has come up in the last 10 years has allowed us to look at the same heart image at the same more than two planes, either biplane or triplane, and you can able to get the same instantaneously, all the segments, what do they contract or how do they contract, how do they relax for the same beat. So this obviates that variation in the beat, variation in the contractility, so one can reliably look at the LV chamber dimension change as well as the volume change as well as the individual segment contractility. From this, you can also measure the ejection fraction and volumes. And here, same way, this is on using the matrix probe on a three-plane method, and here you have a volumetric image acquisition. So by which you are able to acquire the data on the entire heart. This allows you to measure the ejection fraction. Here you can see it, how the volume changes from end diastole to end systole. Again, based on this region of wall motion, everything you can look at. And if you also wanted, you can, for novice, initially when they want to get started, you can use this various multiple sections along with it, which you are able to see, so that you can identify how this is computed. So these are the things that have come up in the last 10, 15 years. But over the last 20 years, changes in the computer hardware, as well as the transducer technology, as well as the computer power support, allowed us to do multiple parallel processing and computation that allowed us to do this. So one of the benefits of this was, so here is a full volume image. One can get it at the same time, and you can see the LV and LA reciprocal changes in RV. And one can also use different areas, different regions, ejection dynamics and contractility very well. So with the development of that, we have also, well, one of the advantages of this 3D, which we are able to get it with a matrix probe, is that you can also look at the shape very well. Here is a biplane TE image in a patient. If you use this image on a basal short axis view, you will get an EF around 45 to 50 very easily. But when you look at entirely here, the infralateral wall contracts, septum is dyskinetic, inferior wall is dyskinetic, basal anterior wall is contracting, and mid inferior wall is contracting. So the EF may not be appropriate and adequate, and you won't be able to see this dyskinetic segment using a mode or even biplane unless this view was taken into consideration. And here, on a live 3D, as soon as you press the 3D button, you're able to see the entire LV, and you're also able to see the dyskinetic large apical, anteroseptal apical aneurysm nicely. So this is the advantage of the matrix probe, what we can do. So beyond the EF, the change of the shape, here the LV is contracting, but it is going in the wrong direction. The effective output is not going out. And the shape change can also be looked at now with the recent, well, I hope this works. It was working, but it's not working now. There you go. We're able to see the shape change, and as a result, how this OD matrix probe, when the data is acquired, it is looking at the strain on all the regions of the circumferential strain, and how it is dysfunctional, is able to show that nicely. So now, the advantage of this is, with the matrix probe, as we are talking about, we're able to, a few other things have occurred in technology-wise. One is, we started doing the imaging of the tissue contractility by masking the higher velocities and enhancing the lower tissue velocities. And tissue velocity was used in order to show from what are the differences in the different areas. Specifically, it was used initially for CRT. But later on, we figured out that tissue velocities alone is not able to help us out of the entire myocardium, because the angle problem and the orientation problem. So then using the same speckles from the ultrasound with which the B scan is formed, why can't we track it down? And people start using the B scan. So here now you can see this very well. So with the B scan, we are able to get the, go back here, we are able to get the strain imaging. So strain imaging, you are able to see, we are able to track the speckles from end diastole to end systole throughout the cardiac cycle. We are able to track it down to where it is. And these things can be marked, and you're able to get a velocity vector imaging, or from the speckle, the computational, it allowed us to get the strain. So with the strain, you're able to look at the myocardial, basic myocardial viability, healthiness of the myocardium. The myocardium is inherently normal, getting its good blood supply, getting its good oxygenation and oxidative processes, everything is fine. The myocardial strain should be normal. So we're able to assess the integrity of the myocardium using the strain. That is one of the biggest advantages that we have got. So in addition to the changes and developed in the technology, allowed us to develop matrix probe, volumetric imaging, as well as using the speckle imaging from the same. So all of them are easily computed now. I mean, of course, since everything is being computed, if anything goes wrong, we don't know how good it is, what not. So that's the reason people keep on analyzing and evaluating and verifying from one center to other center. As you recently noticed that speckle tracking strain rate obtained from different vendors have been looked at by the ASC, and they found out that there is a variation, but the variation is minimal now after they come to the DICOM imaging basis. So we do need to wait. And similarly, 3D has been there, even though it's been there for 10 years. And the first 3D I did was about 2001, 2002. Now things are far better, but still it is not widely used. Even though MR imaging has been shown to correlate by Asha Gopal and Dr. King in 2002, 2003, still we are not there because not everybody is commonly using it. But anyway, so the integrity of the myocardium, you can use the strain and strain rate. And for the contractility, even though we used DPDT in the past, I got to get back to the slide. Somehow or other, with all this confusion, the slide order got mixed. Just go back here for one second. So this is the advantage of matrix probe. Now, one of the things with the Doppler in late 80s, mid 80s to late 80s, what we knew was we can measure the amount of blood that's going in and out of the heart very easily. So this is one of the basic principles on which the echo was developed was law of conservation of mass, which means that whatever the amount, since the heart is a closed circuit, whatever the amount of blood that comes here has to go into the other chamber, and that has to go out. So if you can measure the blood flow velocity here and the area over which is occurring, you can get the stroke volume here. And when this contracts, the same amount of stroke volume should go across as long as there is not much regurgitation or shunt. So in other words, one may be able to measure the amount of blood that's going through anywhere in the body by measuring the area and the flow velocity. But here, even though we had it and we used it, and people try to correlate with the cardiac output with the pulmonary catheter and all, but even now we use it as a number, but we don't quote it. This is the most important one information, if any one of you want to get out of this lecture, is although EF is a measure of the volume change, if I tell you a EF of 30%, what does it mean? 30% in a normal ventricle versus 30% in a huge ventricle. You don't know what it is. So there is not a basis on that. But as a cardiac output, we do know that the amount of blood that has to maintain your circuit has been well known. It has to be around anywhere from 5 to 7 liters and 65 to 70 ml. And if there's no regurgitation and shunt, by measuring the stroke volume, you are able to measure the cardiac output very nicely. So with the Doppler in my late 80s, mid to late 80s, Nishimura and Tajik and Seward and several people have done that. Dr. Hartley, velocity time integral, amount of time and the velocity spread that occurs during the contractility over that period. And if this is the product of the area over it's coming, then you can measure the cardiac output stroke volume very easily. And if the stroke volume is multiplied by heart rate, then you get a cardiac output. So here is a patient where the error that can occur is when you're measuring the outflow tract diameter. But by measuring the pulse wave Doppler alone, very rarely you're going to cause a problem unless otherwise there's a subaortic obstruction or a basal septum that is thick and causing accelerated flow there. Otherwise, by and large, this should be very easy. So in other words, even if you don't get it, if you can get the velocity time integral, if that is going to be greater than 18 to 20, 25, then that means that your cardiac efficiency is pretty good. So even you don't need to get the area alone, but if you don't get it, you can use the BTI alone as surrogate. But anyway, you can use this, and this is one of the most important parameters. Now, this we talked about. Now, I'm going to show you, this is a patient, 40-year-old male, severe pulmonary hypertension. So here, if you look at it, LV size is small, RV is huge, and aortic root is fine. But if you look at it here, and what's going to happen? mode echo EF was given 74. And here, by 2D echo, volumetric echo, EF is 65. And here, you can see that how it's squished. But look at the aortic velocity. Hardly 1 is 0.6. So, if you look at this, and if you measure the diameter of outflow tract as 20 millimeters, and alveolar TBI is 13 centimeter, your stroke volume is 27 ml. So look at here. See, LV function, this is a PA, I've spoken this to Dr. Allegason and a few of my friends. In a PH patient, all of us look for RV function. It's not the RV function. You really have to see whether the progression is occurring in the right direction or not by seeing how much amount of blood is being conducted through that resistive pulmonary circulation. If you are treating them well, if the pulmonary vascular resistance is coming down, then more blood should come to the left atrium and left ventricle. So the stroke volume should be more. On the other hand, in spite of TR velocity may be going down from 4 to now 2.5, you cannot feel good because RV contractility is also good, but the pressure has come down. But on the other hand, RV may be contracting, but there is not much of a volume that is coming on the other side. So the stroke volume is a key important thing that you need to get. Here is a 56-year-old male with heart failure symptoms. And here you can look at it here. LV wall is thick, LV cavity size is small, LV function looks good. EF is about 50% biplane. But he has got MR, but MR looks like a low velocity MR, but is moderate degree, which indicates that LA pressure is high. This is what Dr. Nanda used to say. You don't look at the mosaic area, look at the other area where the velocities are smooth and laminar, which means that the velocity spread is quite far. Look at the Doppler of the mitral valve, restrictive physiology. Look at the tissue Doppler, mitral annulus, significantly low E prime and A prime, but EF is normal. And look at here, in this patient, look at the stroke volume. Stroke volume is extreme. So E prime ratio is about 27, so markedly elevated filling pressure. And look at here, stroke volume. Stroke volume is 38 ml. So here is the case. Patient's EF LV wall is thicker. You may think it is maybe amyloid or maybe infiltrated disease, granted, but your EF is not too bad, EF 50%. If you're going to give that, the doctor is going to think that, but you have to say the stroke volume is low. Here, even though the EF is good, the amount of blood that's going out is extremely low. Why? Because the patient has got a high filling pressure. There's restrictive physiology. Now, in this patient, you can do the strain rate imaging. So apical long axis and apical 4-chamber view and 2-chamber view, and you get the strain. Obviously, the strain is low, it's about 6.4, and you can get the polar plot. So here it clearly points out that even though this patient was not diagnosed, here it is pathognomonic of infiltrative heart disease, amyloid. So the point I'm trying to make is, yes, the strain rate imaging is able to show the myocardial integrity. But similar feature can be caused by other things also. So you do need to put everything together. But it'll tell you the myocardium is abnormal. You don't know why it is abnormal. That we need to find out from the history. But in addition to that, although the EF is normal, look at the cardiac output, cardiac index. That has clearly pointed out that you can't just sit on him, that this guy needs to be aggressively treated, otherwise he's going to go into a refractory shock. Now this is a patient, this is not mine, this was given to me by, I don't know whether it's Ashish or Kiran, patient with aortic stenosis, normal LV size, normal function, LVH is present. And one of the things we deal with aortic stenosis nowadays is that timing of surgery if the patient doesn't have symptoms and if the functional capacity is good. And look at here, strain on this patient already clearly shows it's quite abnormal. So this tells you that myocardium is under stress and myocardium can get better if this is taken care. So there are reports that are coming out, and even at our own center, after the valve replacement in a surgical patient, as well as the TAVR I have not seen, but valve replacement, the strain rate pattern changes. Doesn't come back to normal, but the number improves. So this tells you one to time. More important thing is it tells you about the myocardium. So you can't just depend on EF alone. You have to use the integrity of the myocardium is present or not, and this is a patient with mitral regurgitation. Basically, you've got a flail mitral valve, severe MR, and in this patient, the strain rate is not too bad. There is some abnormality, but still the total value is pretty good. If this was a little bit further down, you can make a case that you need to go for surgery. But here we make a case to go for surgery because to preserve the leaflet and to do the repair. If you want to wait for the patient to have a replacement, then it's not a bad idea, you can wait. But here, the repair is more important. So here in this patient is not abnormal, but there are a lot of papers that have been shown that this myocardial process dysfunction starts occurring in these patients quite a bit, especially those who have mitral valve disjunction. They have clearly shown that regional variation in the strain is associated with myocardial fibrosis, and those are the people where the LV function may be normal, even the stroke volume may be normal, and you may have only a mild regurgitation but severe prolapse, but they present with syncope and because of the VT. So all it tells you is that whenever there is a patient that's got symptoms, you are bound to or obligated to assess the integrity of the myocardium. And here is the same patient whom I showed you before for inferior infarct and biplane EF with 54. And here, look at this. Basically, inferior infralateral valve, and basically the strain rate is clearly showing that it is totally abnormal, infarcted tissue. So, but people have shown that you can see that even in severely hypokinetic ischemic myocardium, after revascularization either by PCI or not, these things improve, at least the percentage of this improves. So that tells you if you are in a bind, patient has got a single vessel disease and the EF is normal and you are optimizing the therapy but you cannot go further up, but whether to do that or instead of doing a WT stress echo or something like that, if the strain is abnormal, then you can make a case for going ahead to revascularize the territory to improve the perfusion. Here is a patient who is basically present with pulmonary edema, got hypertension only for 5 years. This is a 46-year-old gentleman. Because the blood pressure is also obese, obstructive sleep apnea is present, and blood pressure is 160/100, bilateral route and mild mild renal insufficiency. So here you look at it, LVH, even though he's been only 46, look at the left atrium, look at the mitral annulus, look at the aortic valve, mitral valve, all of them are sclerosed and calcified. So which means that the ventricle pressure has been borne by this annulus for a long time. And it's also a metabolic syndrome, looks like. LA is big and difficult window, but yet RA both are increased. And look at the LV, LVH, LV contracts very well. So if you look at the EF is 68%, but the stroke volume, TBI is 14.5 and stroke volume is only 45 ml. But he is presenting with a blood pressure of 160 over 100 right now. And his diastolic function shows E, even if the Valsalva, it doesn't change. And E prime is low, A prime is low. So this fellow, even though he's young, but the disease process must have gone on for a long time. Look at the E prime ratio is 35, very high. So no wonder why he presents. This is a patient with classic heart failure with preserved ejection fraction, presenting with pulmonary edema. So that's what you saw. Now look at his strain. Global strain is minus 15. So you saw the LV structurally normal, no region of wall motion abnormality, and you also saw the EF is normal, and yes, the stroke volume is down because of the elevated filling pressure and as well as the increased afterload blood pressure of 160. Yes, it is down. So that gives you that important information. Checking the blood pressure when you're doing the echocardiogram is very essential, especially not only for AS, where low gradient normal EF AS you can find out if the blood pressure is very high, where your gradient is low because of your blood pressure is high, or even patients with severe MR, now it's mild. What is the blood pressure? If the blood pressure is 180, even a mild MR can become moderate to severe. So you do need to correlate the hemodynamics with the blood pressure. Similarly, you can see the effect of that on a myocardium. People have shown afterload changes, preload changes affect the strain rate. So obviously this guy's LV function is normal, LVH is present. He may have small vessel disease and supply demand ischemia. I'll give you that because the blood pressure is high, walls are thick, so it could be supply demand ischemia. Nevertheless, what myocardium is facing, the strain is showing, and the stroke volume is not normal. It should be more than 60. But in this guy's case, because of why we do know why he is present with pulmonary edema, markedly elevated filling pressure, but yet at the same time, even with the normal EF, his stroke volume is extremely low. So now, this guy was treated aggressively based on the diuretics and afterload reduction. And look at the LV now. Now, the previous LV, I want you to look at, here, this has got a twist nicely, counterclockwise here, very nicely you can see. Now, this is a Doppler. Now, almost trying to get to a grade 1A pattern. This is the old one, nobody uses it now. E is small, A is tall, the EA is reversed compared to. Now, with Valsalva, he is able to further decrease it. Now look at this one, it was 140, it has come down. So, EE prime ratio is 20, it was 35, it come down. Now look at what little blood pressure change as well as decreasing the filling pressure made a big impact on the stroke volume. The LVOT TBI, which was small before, now it has improved. So it is 58 ml. So this clearly points out to you that what do we measure? We measure, we put the probe, we look at the LV, and we measure the automatically MO, 2D, all of them measuring the EF. Then what do we measure? We put the Doppler whether the AS or not and things like that, and we take the information. But that information and this information should be correlated, and you also need to know why this information is low or more, and for that your myocardial integrity requires. So EF alone is not going to make a point. And here is the study, which is so basically normal patient. So you're able to see the biplane image, and you're able to see the triplane image. Now, with the matrix probe, what we have now, one can acquire the volumetric image. Of course, one has to learn how to use it. The new matrix probe, which is smaller, 4V probe, which is much smaller, is like a normal transducer. One has to use it. And one of the important things is play with the buttons and try to get a biplane image, triplane image first. So you will be able to recognize and you feel comfortable. Then go to the full volume data and try to get it. So by that one way you can, once you have to get a one full volume data, you are able to compute everything, strain, as well as the myocardial work index, everything. But the GE, in the case of GE, you have a AFI function. Automatically, you can get three views, long axis, 4-chamber and 2-chamber, and automatically you can choose where you can get the ejection fraction as well as you can get the strain rate imaging. So one has to practice. And here with this, you get the strain and strain follow plot, and you can also get the left ventricular myocardial work index. For this, you need to put the blood pressure. At least by trying to do this, you'll develop a habit of making the blood pressure. I think the most important thing is all of us, we have a, this is one of the things which I want to share with you. You don't need to get the stroke volume because the error can be with the LVOT or flow tract dimension. But try to get it as best as you can. If you can't get it, even VTI alone is sufficient. Normal VTI should be greater than 18 to 20, 22. If there's going to be less than 15, you should start wondering, even though your EF may be normal, you should start wondering, why is it low? What is the reason? Then it will start clicking in your mind that you need to look at the myocardium. You need to look at the other things. Is it because of the MR that I have? Or is it because of pulmonary hypertension that I have? Or is it because of pericardial tamponade or fluid that I have? So it should trigger you in your mind to look at that. LVOT itself is sufficient enough to risk stratify the patient at risk. I think, if at all, if I can express something with you, I think you have over the last 25 to 30 years, 25 years actually, the technological changes in the computer, hardware as well as the software, as well as the computation for different algorithms and different, this one has provided us a platform now where you can, with one probe, you can keep one view, get a full volume data. From that data, you can look at everything that you want. But of course, there's nothing is going to supplant the use of Doppler. And I would suggest that I think volumes, which will help you to get the shape of the ventricle and the ejection fraction, as well as the integrity of the myocardium strain, will be helpful. But with the Doppler, I would suggest that all of you start reporting cardiac output or stroke volume as an essential integral part of your report. And also, what we don't do, I think, which including myself, who might be at fault, is very rarely I try to look at the DPDT. But on the other hand, it provides a lot of information. So in the moderate to severe degree, even though LVEF may be around 55 to 60, 65, you are able to recognize the integrity of the myocardial contractility. If it contracts very well, the myocardial tissue should be fine. So I think incorporating that becomes important, but more importantly, whether you incorporate that or not, I think incorporating the stroke volume along with your EF and a global longitudinal strain is important. I didn't talk to you about twist. I didn't talk to you about radial and circumferential strain because I think there is plenty of data on longitudinal strain telling that how prognostically it is helpful, not only in diagnosing, prognostically is helpful in satisfying the patient. Second, we all know about the value of cardiac index. We all look at it with the Swan-Ganz and all, what is the cardiac in the OR every time. But we measure it, but we don't report it. And we don't even look at it, why is it low, why is it high? And that will make you look at the blood pressure much more carefully. Thank you very much. Sorry for the delayed or difficult start.
So, thank you for the great insight, sir. So shall we move on to the Q&A, sir, question and answers?
Very good. Were you able to hear? I mean, there was no computer problem, right?
Sir?
There was, everybody were able to see the images, correct?
Yes, sir. Yes, sir. Everybody able to see the images. So there are like few questions, sir.
Yeah.
So, what are the methods to assess LV systolic functions?
There are several methods. I think, see, the reason I didn't go over that is it's been well documented in the guidelines, chamber guidelines and every area. The methods are you can use a mode for the dimensions measurement because till today there is nothing there that's going to make a case for a patient to send for aortic regurgitation or mitral regurgitation. You need to have end-diastolic or insystolic dimensions. So you do need to get that, and that will also give you the ejection. So that will, I'll tell you, I'll get it, but I'll get it on a 2D guided M mode. Second is LVEF. I try to use the biplane Simpson method, modified Simpson method, which will allow you to overcome geometrical differences. And I would also caution you, use the view in which the regional wall motion or regional abnormality is present in the biplane. So that will be the next way. And the third method is, the easiest one is, if you guys can practice and get the volumetric image, simultaneous biplane or triplane image, if you get it, there itself can do auto EF, or you can even get the volumetric image, measurement very easily. If you guys are not practicing it, ask your representative to come and help you to teach you, and you will be able to do that very easily. And then the other thing is stroke volume, that you already been doing it. Those are the ways of looking at the LV systolic function in my mind.
So like there's one more question, sir. So VTA of LVOT or aortic valve to be measured for stroke volume?
For stroke volume, I think if there is no aortic stenosis and if there are not much of a problem in LV outflow tract geometry, by and large, that time velocity integral is not going to be very different either at the annulus or just below the annulus. It's going to be the same. So it is going to be the LVOT test that you have to get, which is in the LV outflow tract just below the aortic annulus, the pulse Doppler, without much angle. It should be parallel to the flow.
So there's one more question. So why much importance is not given to stroke volume and cardiac output?
Not that it is not given, it is given, but we don't use it. I mean, see, when you're doing 30 to 40 echoes, all you do is look at the LV, and we've been ingrained in our mind since late 60s, early 70s, LV dimensions, LVEF, based on that, and LVEF has been a very important integral part of our management over the last 25 to 30 years. Only over the last 10 to 15 years, we have been finding out all these things because of the computer help. We have to thank NASA, we have to thank the American government, we have to thank the European physicists, all of them putting together. We have developed a lot of things which we are able to use. It's like, that doesn't necessarily mean, it's like telling that how come people are not going by bullock cart. If you don't have a car, if the car doesn't work, and if you have to walk this thing, that's the only mode you will do it. So we had that, but now we do have these things. So these things are pointing out the limitations of those techniques, and that's the reason we are not. But I think stroke volume has been there since late 70s, early 80s onwards. That we do have to, there is no excuse for not reporting the stroke volume or cardiac index. You don't need to do a cardiac index, because if you have a way of developing a body surface area, and you can integrate your stroke volume, even the dimensions with that will be better. But at least giving a raw stroke volume, people can know for that person whether it is okay or not.
Answer, like there's one more question, like what heart rate we should measure strain?
I think most of the strain data which has been is when within the normal range, basically anywhere from 60 to 100, 110. But the faster the heart rate that goes, what might happen is you're going to be interfering with the frame rate. So you do need to have at least a frame rate about minimum of 45 to 50 in order to get that, even with the current way of doing it. But still, when the heart rate goes up, you don't have during the systole to measure the peak systolic strain. You don't have that amount of frames can be occupied. So when the heart rate goes beyond 120, 130, it becomes very difficult.
So there's one more question. Role of 3D echo for LV function, role of 3D strain.
I think the role of echo for LV function is very, very crucial. I mean, it was 1989 when we did the 3D echo using the registration method. We compared it with MRI and nuclear, and they correlated quite well. And it was published in an obscure journal called Angiology. That was in 1989. The reality is now 3D has come so far away, you are not able to, I mean, you can't even imagine. You put the probe and you press the real-time button, you're able to see the entire heart, both the depth as well as the other planes very nicely, and you're able to see the structure. The one which I showed you where the aneurysm, how it's outpouching, you're able to see it very nicely. So it is there for LV function assessment, especially when your patients are having heart failure patients. There, it becomes really, really important that you do measure the volumetric measurement. But you also have to realize that when the LV is too big, where you really need the volumetric image, the probes and other things also fall apart because we really don't have the kind of a wide angle in order to accommodate. So there are some limitations also. But the way to overcome that is, as we have pointed out by Dr. Yang and ourselves long time ago, one thing is doing a full volume data, other thing is doing a regional data. So you can use the same one and look at a particular region and correlate it. So now to answer your question, I think 3D echo is essential if your practice is involving a lot of heart failure patients where you want to use for CRT, for timing, as well as the regional contractility you want to know, as well as along with the 3D now, you will also get the strain, and which will give you the integrity of the muscle. What you may see the area is kind of not contracting, but the timing wise is fine. But there is no point in putting the lead there since it is delayed. But if there is not going to be any, the strain is going to be totally zero. So it will help you a lot, 3D strain as well as. But personally speaking, there are a lot of issues with the 3D strain because if you look at it, there are a lot of extrapolation of the data, interpolation of the data as the beam goes further down, even though it's supposed to be overcome, and we are not quite sure. Vijay has done a lot of work on that, and it does help, it does work, but on the other hand, there are not many centers have done that to validate. So what I would suggest is that using the matrix probe and getting the 3-plane, and that has been well validated by everybody, global longitudinal strain from 3 different views, which basically gives you a complete ice pick of all 3 different regions, territories of the coronary supply, and that gives you almost similar information. But it's not a bad idea to start doing volumetric imaging and practicing it. And as far as my recommendation, I don't think that I would recommend you to practice, but I won't use the 3D strain as such to this thing, because we still need a lot more data. A lot more centers have to come out with the data to say. That's the reason the quantification area also, the AAC has not recommended that as a method, even for echo EF measurement also.
So should we use multiple parameters to obtain correct LV function?
That is the crux of this talk. You your LV function requires for you to describe the integrity of the myocardium. The strain is going to help you there, able to tell you how the geometry of the ventricle and their ejection, their function is contractility is. So that's where your stroke volume and ejection fraction both are going to stay. So you need to use EF. You also need to do the cardiac index or stroke volume, and you also need to provide GLE. But will I do everything on every patient? No. You have to choose. For example, it's very rare for somebody to have an abnormal heart if your E velocity and E prime are normal. If your E prime is normal and E velocity is normal, unless otherwise you have constrictive pericarditis, you're not going to have any other disease. Your myocardium has to be healthy. If you don't have a healthy myocardium, then it's a story. So basically, you're going to do a routine echo. There lies the matter. You see the LV, size, function, everything is normal, and E prime is normal, then you don't need to worry about it. There, you do need to give a stroke volume though, because stroke volume depends on the blood pressure, it depends on the loading condition, pre and after load. So there it will allow you to think, why is this guy's got a normal heart, everything, but the stroke volume is low. So then it'll allow you to recognize whether the patient has got hypertensive or high afterload or what else is going on. So I think I would suggest that using the basic echo parameters, looking at the LV diastole is crucial, whether you want to do a strain or not. If it is normal, unless otherwise suspecting pericarditis by clinical history, then there's no need to do the global strain. There's no need to do the details of whatever I said. All you have to do is you have to do a cardiac index. That'll be fine.
So there's one request from the participant. Sir, very good deliberation. Can you show your first slide again?
First slide again. Very first slide. May I ask who's asking this? Anyway, it's good. Well, we're going back. Let's see. Here, this is the first slide. Ability of the heart to fill at a low enough pressure, not to cause pulmonary congestion, and then deliver a sufficient quantity of blood to the vasculature at a high enough pressure to perfuse the tissue and to augment this performance during exercise. I think Keith, and there are several people, the Arthur Keith, when he was delivering a Harveynian lecture, there he has written a treatise on the myocardial fibers and how it implies the cardiac function. There he has stated this. I mean, I paraphrase him because the way he has stated it is too high-flown English language for me.
So, there's one more question. Which is the best method to calculate LVEF, and what is normal EF? 55% is normal EF. How to report LVEF? 55%, 60% or more?
I think you need to give a number, whatever you number. The best method to get the LVEF, get the what do you call it as the best method, measure the EF biplane and triplane. If you can get a biplane or triplane, trying to measure from that and get the EF, that'll be the best. And trying to keep the sector taut enough to include the entire heart so that the frame rate is high and also have the optimum gains, no clutters in the cavity, then that will allow you. And nowadays, a lot is made easier. In the olden days, we used to, I think Dr. Alleghase and the older people in the audience will know that even for mitral stenosis, we used to measure the pressure at time. For aortic stenosis, we used to trace this thing to measure the gradient. So nowadays, machine is able to do everything. So all you have to do is, even automatically it traces the edges, then you look through and edit the edges for the proper endocardial border then in 3 different views, and you're able to get it. So the best way will be is to get a biplane or triplane. If the patient does have a abnormality of the regional wall motion or geometrical difference like what I've shown, then probably including that in the view is important. So this is a work which Dr. Berlovic and myself were shown in 1994, that volumetric image compared to biplane doesn't help unless otherwise the biplane includes the region of interest, which is also affected by the disease process. So then the biplane and the volumetric image information by 3D correlates quite well.
So on the next question, thank you for bringing in the hemodynamic perspective and other factors for assessing LV systolic function. How do you assess LV function after coming off cardiopulmonary bypass?
Well, it's very easy. After coming off the cardiopulmonary bypass, the thing is, you do have to realize that they're going to be on norepinephrine, and they're going to be on vasopressin, and they're also going to be on the dopamine, depending upon what it is. So you do need to know how much are they on and what it is, because obviously they are going to drive the contractility even when there is not going to be much load going on. Similarly, you also have to make sure that the systolic blood pressure, I always tell them when they're coming off of the pump, I am not worried as much as about my LV function. I'll just wait there, allow them to get to the normal blood pressure. If the blood pressure is normal as they went in, with the volume stated is normal, then I look at the LV function. If the blood pressure is not as normal as it was when they went in, then your bets are off, because then you need to tell them, you know what, I think the contractility EF is not bad, it contracts very well, but if the afterload is low, the systolic blood pressure is only 60, 70, you really can't. Or sometimes the systolic blood pressure is only 90, but the LV is like contracting vigorously, then I'll tell them the volume is so low, so you need to give some more volume, then you look at it. So you need to make sure that the afterload is okay, you need to make sure the preload is okay before you start interpreting the contractility against which the ventricle is contracting. Then the normal EF is anywhere between, I think people have been changing it again and again. I think it can anywhere vary from 55 to 70, 75 in a young person. It can go on. If you are volume depleted, it can go up. If you ran and stopped suddenly, then you can. I think the normal EF is anywhere around 50 to 70.
The next question, in case of aortic stenosis, way to take VTI in which cut plane? Any significance of LVOT diameter measurement?
I think yes, there is a important information. LVOT diameter is crucial to measure the valve area, but is it essential to diagnose the aortic stenosis? No. So you do need to do the parasternal long axis view, optimize your gain, and take away from the harmonic imaging, which is a normal preset now for most of the images, then measure and even try to adjust the gain to measure the LV outflow tract diameter. So that's one way. And if there is a basal septal prominence, or sometimes what happens is, which Dr. Solomon Victor has shown it to me many, many times, that base of the septum and the right cusp or non-cusp adjoining area can be joined together. So you won't be able to see the annulus at all. So you'll be thinking it may be saddling the base of the wall. So it's going to be very difficult sometimes. So those kind of cases, it'll be very difficult to measure the valve area as such. But luckily those cases are far and few. And now we do know, looking from the aortic sinus, you can go down below where the sinus stops, you can measure it. So we do use that in order to overcome that. But nevertheless, from your point of view, is LVOT TBI, as Dr. Allegation recently, one of the talks he showed, but sometimes you put a CW Doppler, you're able to go through the outflow tract as well as the aortic valve long as the beam is parallel, and you get both the velocity underneath, which is going to be V1, and the maximum profile, which is going to be V2, which is stenosis. So then you can use that as a V1. Otherwise, you do the pulse Doppler in the outflow tract, below the aortic valve, avoiding the bulge, and put the color Doppler first. The color Doppler shows flow conversion and aliasing. Then put the sample volume below that. So then measure the LVOT VTI. The ratio between LVOT VTI and aortic VTI, that is V1, V2, if that ratio is going to be less than 0.25, it is severe stenosis. So irrespective, most of the time we are seeing, very rarely nowadays with the low gradient, normal EF, you are able to see there are the borderline areas where that V1, V2 ratio is also not that helpful. But in a classic case of aortic stenosis, I don't think this is going to be a problem. V1, V2 ratio, most of the time, it gives you a hand even if you can't get aortic valve area. What is the other part of the question, Kiran?
So, any significance of LVOT diameter measurements?
This is a significant LVOT diameter because there are several things that nowadays for TAVI, you need to know the LVOT diameter, even though they get it by my CT, but many a time the CT also, not all CT readers are experts. They're also learning, like all echocardiographers are not experts. So all of us develop and learn at the same time. So there are errors. Even at Mayo Clinic, I've seen the surgeon who was ready to put in the interventionalist and surgeon who was ready to put in a TAVI valve, Dr. Chandra with the CT reading and all, it is the annulus is going to be 23. We're going to put in a 25 or 26 valve. That's what we have decided. They'll say, and you go there and measure and try to look at it. How come you guys got it? I'm getting only 19. You can't put more than 21 size valve here. There's going to be a problem here. So what is it? Then you go back and look at the CT. Then you your cord with your pants down. So the most important thing is measurement of the aortic root is essential. You need to practice, and with practice you get better. There, the volumetric imaging will help you also. Dr. Feigenbaum, long time ago, clearly pointed out that you can measure the outflow tract with the 2D itself. You can go out, back and forth in the scanning up and down, and from the annulus, you'll be able to avoid the basal septum. Especially with the 3D now, you can do the same thing, and you will be able to find out exactly where the septum starts and the annulus begins, and you can measure that. So, but the point is, it's very easy for me to say, but there are times it's very difficult, even for me, you have to go back and forth and try to find out exactly where it is, because the number what you're going to give, they're going to be hanging their hats on that in order to choose the valve. So in the olden days is a lot more difficult because people used to do homographs. So there you have to tell them half an hour to 45 minutes before what the root size is, so that they can thaw the homograph from the freezer and they can put it so that it becomes a deep freeze. So, but JO and our institution, we have shown that transthoracic echo, LVOT dimension, and Hagar dilator used dimension in the OR, they correlate quite well. So I don't think you should have more of a problem. Don't get frightened about it. Just follow the cusp where it inserts. If the basal septum is quite prominent, then in that case, that is a true anatomical abnormality. You got to mention that. If that is the case, then they can't even put in a valve there, because it's going to be causing a problem for them in the TAVI also.
So one last question, sir. Keeping RV and RA while doing 3D volume F for LV is a wastage of space and compromises the frame rate. Would you recommend? And also, should we keep window for LA or only the LV to be covered?
I think the important information here is, if you're quite correct, whatever you said. There's no reason to have the RV when you're looking for the LV volume. There's no question. And also it will increase the frame rate if you have a smaller sector and smaller thing. So you're fine just focusing on the LV alone. And how much are you going to gain by, unless otherwise you're going to do a zoom mode by which you can't. So no matter what you do, your volumetric image, when you're going to be acquiring, it is going to be acquiring along the entire line. So LA is going to be there no matter what. So my suggestion is keep the LA, then you will be able to see the reciprocal volume. And for some reason, now I think some of the machines have a way of automatically doing the LA and LV reciprocal volume, like a hot model in Philips and also in Siemens and GE. Also, you can do that with the Echo Pack, and which can be done on real time also. I think it is important, but I do agree with you. There's no necessity the RV.
So thank you, sir, for the very informative session. We have got a great reception from the audience. I'm sure the clinical cases are going to help our viewers in their practice. Thank you once again. A big thank you to all viewers for your continuous support. Stay tuned for our next webinar session, which will be announced soon. Thank you, sir.
Thanks. Bye-bye.